but kindly adhere to your time. The next speaker on stage is Dr. Aravind Ramanathan, scientist and inventor, Allodox India Private Limited, Chennai. He will deliberate on novel, non-invasive tool to diagnose renal allograft rejection.
Good morning all, and thank you very much for inviting me here to give a talk. Disclosures: I'm a scientist and founder director of two laboratories that intensely focus on transplant genomics. One is supported by MSME, the other one is supported by Startup India Grant, Startup Tamil Nadu. Following organ transplants, protocol biopsy is performed to evaluate the health of transplanted organs. In case of heart and lung, the biopsy is performed at least 3 to 4 times in the first year, thereafter once every year. In the case of kidneys, I'm not sure, probably you're following the same protocol, or whenever it is indicated, especially when there is proteinuria, high creatinine, high DSA, and or when the urine output is less. The downsides of biopsy is that it is an invasive procedure. There could be a geographic miss. For example, the rejection could be happening elsewhere, but the biopsy would come from a normal tissue region. There's a risk of sampling errors, poor prediction value for near future or forthcoming rejection events, inadequate correlation of clinical and biopsy-proof rejections, risk of scarring of organs. I'm sure most of you must be experiencing these kind of issues. The liquid biopsy stands on the other side. It's a non-invasive procedure, requires only 10 ml of blood, diagnoses forthcoming rejections in real time, and there's a good correlation between clinical and liquid biopsy findings, and also it's a good correlation with conventional biopsies also. Since it's non-invasive, it's not painful or there is no risk of scarring. You should note that liquid biopsy is also referred to as donor-derived cell-free DNA or cell-free RNA. So why do we call this as a cell-free DNA? Because at the time of rejection, the cells in the allograft begin to die. They undergo programmed cell death, which is also called as apoptosis, during which the cell membranes, they rupture and release the DNA and RNA molecules into the bloodstream. Since these DNA and RNA molecules are outside of the cells, they are called as cell-free DNA or cell-free RNA. So now we have to have a method to analyze the cell-free DNA. So what we do in the step 1 is we try to identify the donor-specific markers. See, donor and recipient-specific genetic markers are very unique. They are like, our fingerprints. They same way, like, the donor gene marker and recipient marker are usually very unique. So in the first step, we compare and identify the donor-specific genetic markers. In the next step, we take 10 ml of blood from the recipient and separate the plasma. And from the plasma, we extract total cell-free DNA. Once the cell-free DNA is in our hands, we use different technologies to evaluate the amount of donor-derived cell-free DNA. Technologies that are available include next-generation sequencing technologies that were developed by CADDx. It's also called AlloSure. It is marketed in India through Alpha Labs. There are other technologies called as massively parallel sequencing that is developed by Natera. The third one is the real-time PCR. The first two technologies were developed in America, and they're prohibitively expensive due to the inherent complexities of the technology themselves. The third is the real-time PCR, which is much economical, and I have invested quite a lot of time in developing it in India. Following organ transplantation, there is an exponential decay in the amount of cell-free DNA. This is an example of the slide from heart transplant recipients, but the same holds good for all the solid organs like liver, kidney, and lung transplants. So within 2 weeks of transplantation, the cell-free DNA reaches baseline, and it continues to stay like this for very, very long time. So if you do a biopsy procedure and take blood after 1 hour, 6 hours, 12 hours, or 24 hours, you will see that in the first hour there will be very high amount of cell-free DNA, and then it will exponentially go down. In 24 hours, probably you will never see any of the cell-free DNA. Why? Because blood will not keep any molecules that is not required for its optimal function. So it will be cleared from the system very rapidly. But in the case of rejections, the cells are undergoing cell death all the time, and they are releasing the cell-free DNA into the bloodstream. So we will be able to detect the cell-free DNA in case of rejections. With the higher grade of rejections, you will not automatically see a very high amount of cell-free DNA. So this is a representative slide from heart allograft recipients. You can see that ACR with grade 2 rejection, you can see a high amount of cell-free DNA. The same holds true in case of antibody-mediated rejections. So AMR1 has lesser DNA content, and AMR2 has a very high amount of DNA. When we compare the ACR and AMR rejections appear to have more amount of cell-free DNA, simply because this is being antibody-mediated. They bombard these allografts with so much of antibodies. There is enormous amount of cell death that makes that releases large amount of cell-free DNA into the system. So that's why we see a large there's a huge increase in the level of cell-free DNA. When you come to kidney allograft recipients, this also holds good. In case of no rejections, you will not see any kind of you will see some basal amount of cell-free DNA, but in case of active rejections, the cell-free DNA level increases tremendously. The creatine level not necessarily may mean rejection, because even the creatine level could go up for non-rejection reasons as well. So in this paper, the authors very clearly showed that even in kidney allograft recipients who are suffering ABMR, they have a high amount of cell-free DNA compared to those with TCMR. This is quite understandable, because when there is an ABMR, there will be enormous amount of cell death and release of the donor-derived cell-free DNA. So that's why you see a huge amount of elevation in the cell-free DNA related to TCMR. In group of patients where you have both ABMR and TCMR, the cell-free DNA level is somewhere intermittent. The authors also showed the amount of cell-free DNA in various renal pathological lesions. I'm sure most of you will be aware. I'm not, because I'm just beginning to understand the kidney allograft segment. So you can see that whenever there is microvascular inflammation, the cell-free DNA definitely goes up. Even in case of glomerulitis and peritubular capillaritis, you can see a significant level of cell-free DNA. The knowledge what we get from here is that even though these pathological lesions do not fit into a strict the criteria of rejections, whenever there is a dysfunction, organ dysfunction, this can lead to an elevation in the cell-free DNA. Interestingly, when the cell-free DNA is elevated in the presence of donor-specific antibodies, it becomes a strong indicator of ABMR, because DSA positive alone does not, without cell-free DNA elevation, does not indicate ABMR, but DSA plus cell-free DNA indicates ABMR. Cell-free DNA is elevated days, weeks, months ahead of rejection. So it acts as a strong surveillance tool, a predictor for future rejections. Up until now, I presented the data that were generated by the aliens. So right now, from here, it's all based on our experience. So I have personally analyzed, done liquid biopsy on kidneys, lung, and heart. And this is a little bit old data. Now we have reached more than 350 samples so far. So if you see focus only on the positive and negative prediction values, so negative prediction value here is very important. When there is no rejection, you should be able to say that there is no rejection. That is very important. In case of heart and lung, you see the negative prediction value is more than 90%. This is comparable to other available technologies in the market. In the case of kidneys, it is around 80% as of now, but now with the advance of the technologies that I have developed, I'm sure that this will also reach close to 95 to 96%. The positive prediction value is equally important because when there is rejection, you should be able to say that there is rejection so that you can initiate appropriate treatment. So this rejection, positive prediction value is definitely more than 40% in all, and I'm trying to refine the technology so that the positive prediction values also reaches more than 90%. The presence of DNA, does it always indicate rejection? No. I mean, whenever there is an infection, also, like we have seen that elevated amount of cell-free DNA. This is also true in case of kidney allografts also. There was a patient with BK virus, and we saw an elevated level of cell-free DNA. So after the immunosuppression was refined, the BK level went down, and the cell-free DNA also went down. So there is a very good relationship between the infection and rejection also. So in this case of an example, you see the 2 time points, right? We saw an increase in the cell-free DNA concentration at both time points. Biopsy was normal. In the BALD report, the bronchial lavage report showed that there is Acinetobacter infection. This is from the lung transplant. So this early on, this was happening very number of times. There was elevated cell-free DNA. Patients were normal, clinically normal. Biopsy was normal. So we wanted to develop a technology that was clearly able to diagnose rejection accurately. So that's when I developed the cell-free RNA technology. What I do here is that I use an organ-specific marker. For example, the marker that is expressed by the kidneys is not expressed in any other organs. It's not expressed in liver, heart, or lungs. Same way, I have markers specific for each of these organs. So I have to mention that globally we are the first to achieve success in this technology, in diagnosing rejection. So I'm going to give a few examples here. So this is from a lung allograft recipient. You can see that there are 3 time points. Day 90, cell-free DNA is high. There is no cell-free RNA. Biopsy was normal. BAL report showed TB. Day 310, cell-free DNA is high. No RNA. Biopsy is normal. Still there is TB. Day 430, DNA is high. RNA is high. And there is rejection in the biopsy. BAL report says no infection. So what is clear here is that when there is rejection, the cell-free RNA is able to diagnose it accurately. But cell-free DNA appears to be high much earlier. There's also another way to see this report. You see, the cell-free DNA has started increasing from day 90 onwards, which means that cell-free DNA is able to predict the forthcoming rejection. I'm going to show you one more slide here from the heart transplant recipient. At day 40, DNA went up, RNA was not there, biopsy was normal. Day 90, cell-free DNA was high, RNA also was high, biopsy showed AMR. So again here, the DNA went up on day 40, but RNA was not there. So it means that cell-free DNA can act as a predictor. So this is an example from a combined heart and lung transplant recipient. So combined heart and lung transplant is very complex because we should be able to say which organ is actually undergoing rejection. So on day 30, DNA was high, lung RNA was not there, heart RNA was there, biopsy showed rejection of heart only. Day 90, we did not see DNA, lung RNA was not there, heart RNA was there, biopsy showed rejection of heart only. And day 210, DNA was higher still, but no RNA of lung, no RNA of heart, biopsy showed normal. So again, this reiterates that the RNA is able to diagnose rejection accurately. So when we compare the cell-free DNA with cell-free RNA appears to be diagnose better, both in case of positive prediction value and negative prediction value in combined heart and lung transplants. So if there are going to be combined liver kidney transplants, then probably we'll have to use this particular technology. Now the questions most of you would have is that, well, I told that cell-free DNA is a good predictor, cell-free RNA is good in diagnosing rejections. So which technique am I going to use for my patients? That's the question you all must be having. The answer is, you can use cell-free DNA as a surveillance tool, because the cell-free DNA reaches basal level in 2 weeks, within 2 weeks of transplant. So you can start this test from 3rd or 4th week and then continue to do this for another 6 months or maybe 1 year. And if the cell-free DNA level is going to be close to basal level, these patients are going to do excellent. If you detect cell-free DNA, if it is elevated, then that means that there's an underlying pathology. You can decide to do a biopsy at that point. Right? You don't really have to do a protocol biopsy. You can do a biopsy if the cell-free DNA is elevated. Now, cell-free RNA you can do when you are suspecting a rejection. Say the urine output is less, creatinine is high, BK virus positive, or you know the clinical presentation that is associated with rejection. When you suspect a rejection and if you think that it is the situations do not permit to do a biopsy, then you do a cell-free RNA test. It can indicate if there is cell-free RNA is negative, biopsy is certainly going to be stable. If cell-free RNA is positive, it will be definitely a rejection. So recently we did this particular test on a patient with a kidney transplant recipient with the AMR, and we were able to identify the rejection also, both with cell-free DNA and cell-free RNA. So cell-free DNA can be used as a surveillance. If you say, you know, this example for 3 patients, okay. So the blue bar, the patient in the first month showed very high amount of cell-free DNA. By 3rd month, it was negligible. At 6th month, it was very close to basal level. The patient 2, the orange bar, first month was higher, 3rd month was higher. By 6th month, he developed rejection. The 3rd patient, the green bar, was very high even the first month and went to rejection immediately. The 3rd month, there was no rejection, but DNA was still higher. 6th month, there is no rejection in the biopsy, but DNA is higher. He still continues to, it continues to be higher in this particular patient, and we suspect that he's going into chronic rejection because his oxygen saturation has come down. This is from a lung transplant patient. So this clearly shows that you can use the cell-free DNA as a surveillance tool. Okay, that's about the liquid biopsy. I think this CYP3A5 genotyping test, I think many of you are aware. There's an extensive metabolizer and poor metabolizer genotypes. Extensive metabolizer metabolizes very fast. They need very high amount of drug. Poor metabolizers, they metabolize very slowly. They require very, very low level of drugs. By doing this particular test before the transplant, you will be able to achieve target tacrolimus much faster and very comfortably. I think many of you here are doing it already. So there are several inventions in pipeline. One of it is that I'm trying to develop a technology to predict optimal immunosuppression from untouched T cells. So all you have to give me is whole blood in ACD tubes. Then probably I will be able to tell you with a kind of a fluorescent switch, I'll be able to tell you whether the immunosuppression is optimal or you will have to adjust the dosage. So since inventions is part of my business, I invent quite a lot of technologies, and if you have any challenging areas, then you please do let me know. I will try to invent those technologies. Thank you for your time. I'm done.
Thank you very much, sir. That was wonderful. You finished on time. And